I have the honor, the privilege to present this very important data, which are the final results of an important study, DASISION, which started more than 5 years ago, almost 5 years ago, in which Dasatinib, which is a potent TK inhibitor, was compared with the, let's say, classical or therapy represented by Imatinib 400 mg once a day. The dosage of Dasatinib was 100 mg per day, a single administration, and the patients, therefore, first-line patients, so a diagnosis, they were randomized to receive Imatinib or Dasatinib, and 250 patients were enrolled in each arm. The results are very impressive in favor of Dasatinib because what they show is that there is a deeper and faster achievement of molecular response, even in terms of what we call a major molecular response, which is represented by a 3-log reduction with respect to the median amount of presented diagnosis, even in terms of very deep molecular responses like ML4, ML4.5, and this is occurring across all the different groups of patients irrespective of the original risk factor that in the DASISION trial was the ASFR risk scoring system. And this was obtained, these better results were obtained in spite of a really acceptable profile of toxicity in comparison, of course, with the Imatinib, in which the only problem was represented by the occurrence of some cases of pleural effusion, and these pleural effusions were however manageable. Indeed, only very few patients had to discontinue the therapy because of the pleural effusion, and what they did generally was just to restart the treatment, and in some cases they have to take a reduced dose of the drug, which is substantially the meaning of this trial, which is very well integrated with the results that have been obtained by the British group and by the trial called Spirit 2, which will be presented after me by Professor O'Brien, is the fact that indeed just to use a stronger TK inhibitor can in the first of all can inhibit some of the early progressions that are still occurring in patients, I would say not immediately, but in the first months after the start of the therapy. And this is probably due to the fact that the Dasatinib is able to overcome the resistance of some clones, which can be characterized by the presence of some mutations. Indeed, the mutations profile of the patients that showed a clonal re-expansion of the disease with Dasatinib or under Dasatinib treatment or under Imatinib treatment was quite different. In fact, there were more T359 mutation which were present in the Dasatinib treated patients with respect to the Imatinib treated patients. And this is indicative of the fact that the mutations that are sensitive to Dasatinib but insensitive to Imatinib are indeed suppressed by the Dasatinib treatment. The other important point is that deeper molecular response, which is the meaning of obtaining a deeper molecular response like ML4, ML4.5. We do not know at the moment if there is a great advantage in terms of overall survival, and indeed in the entire cohort of the patients we didn't observe an increased overall survival. But the deeper molecular response may suggest that there will be in the future the possibility to have a real cure, and therefore the possibility to really discontinue the therapy without having a relapse of the disease. And this is little by little becoming the next goal of CML therapy, that in terms of overall survival has already achieved great results, but which for the moment is still requiring a continuous, we can say, lifelong therapy for the patients. And there are, however, now studies that show that indeed is possible also in some patients, even the disease is not totally not totally disappeared, it's possible to discontinue the therapy without observing a clinical relapse of the disease and without any sort, for the moment at least with the period of observation quite limited, of a risk for the patients in terms of progression of the disease and so on. So, although not such a dramatic change as we observed in the early 2000s when for the action of Imatinib there was an extreme increase in the survival of the patients, little by little we are optimizing the therapy of CML patients. And we are, of course, improving little by little the results in a specific subgroup of patients which can still be resistant to the Imatinib therapy. Of course, the strategy that we have to use to start with a second generation TKI from the beginning with Dasatinib, or just to continue with the traditional strategy which contemplates to start with Imatinib and then in case of resistance to move to Dasatinib is still, I would say, a matter of debate among the specialists and so on. But what is really important that we are little by little improving in terms of results. I think that in the future we will adapt our strategy to the different kind of patients that we are facing. For very young patients, of course, it's very convenient to try also or to give them the possibility to discontinue the therapy sooner or later.